Thank you all for being here today at our Friday noon talk. I have someone to speak to. Today we have the pleasure of welcoming Dr. Marjorie Gonzalez. She is a nuclear medicine physicist at Interior Health in Kelowna, BC, and she will be speaking to us today about her work in nuclear medicine. I'll let her introduce her title, but Marjorie, I'll hand it over to you.
Awesome. Can you hear me? Still okay?
Yep, it's coming through.
Okay. Awesome. Okay. Okay, yeah. Thanks everybody. I did spend in my previous life, I did spend some time in Montreal. I started in academia as a astronomer. So I did my astrophysics PhD at McGill before I switched over and I started to do medical physics. So yeah, lots of good memories from Montreal. Good spot. So okay, so right, so I am going to tell you about this program that we have in BC, where last year we started a to roll out lutetium-177 PSMA therapies across the province. And so I and it so that so I'm just gonna tell you about all the work that we did to get that going and where we are right now. And so nuclear medicine. Nuclear medicine talk. And I'm not sure how you guys do the questions. Do you do them all at the end, or do people ask questions as we go?
At the end, usually.
At the end? Okay. All right. Awesome. Okay. Sounds good. Okay. So what we're going to talk about today, so radiopharmaceutical therapy, and specifically lutetium-177 PSMA. The commercial name for it is Pluvicto. So I might jump back and forth. So I might say lutetium PSMA or I might say Pluvicto, but it's the same thing. And so I'll tell you about how we rolled it out across BC. So how we rolled it out from going from just clinical trials at one center to rolling it out to multiple sites across the province. So the challenge that we had, how we approached it, how the protocols and documents that we had to develop, the calibrations that we had to do for our equipment and for our SPECT cameras. And I'll tell you some of our results so far and the current status and some conclusions about that. So okay, so nuclear medicine. So just in general, hopefully we're all familiar about with nuclear medicine, but just in general. So in nuclear medicine, we have both diagnostic or monitoring of diseases and therapies as well. Also, can you see my mouse? Can you see it when I'm moving it? If I point to something, can you see it?
Yes, we can.
Okay, awesome. Okay, good. Okay, good. So great. So right, so yes, in nuclear medicine we have both diagnostics and we have therapy. And we also have imaging and non-imaging. And as part of the imaging, SPECT accounts for about 60% of the imaging that we do, and PET accounts for about 15%, just in general. So what we're going to talk about today is therapy. And it's a therapy that also combines imaging with it. And the imaging that is involved with it is SPECT. So those are the ones. So and just so that we're all, just so that we're all on the same page. So for radiopharmaceuticals, we are injecting into the patient or they are inhaling it. So we're giving it to patients to image functions, of organs or tissues or to treat certain diseases. And what we do is we attach a medicine or a molecule, so a pharmaceutical, to radioactive material, to a radionuclide, and then we get a radiopharmaceutical for that. So this radiopharmaceutical, we might do it for diagnostic purposes, but what we're going to be talking about today is for therapy, because for therapy is our growing the part of nuclear medicine that's growing more at the moment as far as clinical usage goes. So it's almost exploding a little bit, the amount of therapies that we're going to start to do in nuclear medicine. So in just the past few years, from 2022 to 2024, it's grown by about 30% just in a few years. And there are hundreds of trials that involve radiopharmaceuticals just in the US. And in this graph, I'm trying to show, like just how many there are and how many preclinical trials, phase 1, phase 2, phase 3. And at the bottom, I'm showing what's in clinical use, but for new radiopharmaceuticals. So we have 2 new radiopharmaceuticals for therapies, but all of the preclinical work and trials that is going on, there's going to be a lot more coming our way. So sometimes we think of it as a little bit of a tsunami. There's a lot of that's going to be coming and going clinical very soon. So this is part of the work to get ready for that. And just to give you an idea, so what kind of radiopharmaceutical therapies are we doing in Canada right now? So this diagram kind of tells you, so we're doing thyroid cancer therapies, hyperthyroidism therapies, those ones with iodine 131, we've been doing them for 60, 70 years. But there's been a lot of them that have been coming online for neuroendocrine tumors, prostate cancer, bone metastases. But the ones that have been new, the ones that are new from the last slide are these 2 that involve lutetium-177. So there's been 2 new ones approved in the last 5-6 years in Canada. And dotatate for neuroendocrine tumors and PSMA for prostate cancer. That one was approved. So that's the one that we're going to talk about today, PSMA. So that one was approved by Health Canada in 2022. So late 2022 was approved in Canada, and at least in BC, it's now, because of all the work that I'm going to talk about today, that we have started it clinically. So it's taken about 3 years to get that into the clinic broadly, at least in BC. So what are these radionuclides that we're using? So the main ones that we're using clinically are I-131, the one that we've been using for a long time. That's a beta and gamma emitter. Lutetium one is the one that we're starting now, and it's also a beta and beta and gamma emitter. Y90 we've been using for a while. That's a pure beta emitter. And a somewhat new, but by new I mean 10 years by now or so, it's radium-223, and that's an alpha emitter, but also beta and gamma. So these are the main, so clinically in hospitals, these are the main radiopharmaceuticals that we're using for therapies at the moment. So lutetium is the newest one out of all of them. And you see there, it has a half-life of about 6.5 days. But it is excreted. The effective half-life is a lot shorter than that because it's excreted a lot faster. And we're going to talk about this therapy, but it's not for therapy. It's not just given once, but it's given multiple times to patients. And we're going to talk a little bit about that. But so these are the main radiopharmaceuticals that we're using right now in the clinic. Every week we're using these guys. So Pluvicto, so lutetium PSMA therapies. So this is for prostate for metastatic castration-resistant prostate cancer, and as the name suggests, PSMA in the title, it binds to the prostate-specific membrane antigen, and it's a protein that is expressed in most prostate cancer cells. So it's a targeted therapy. So it is meant to be binding to cancer cells mainly. It will bind to other tissues as well, but it does have a high tumor to normal tissue uptake. So it's a pretty good target for that one. And because it's both a beta emitter and a gamma emitter, you can use the betas for treatment, and you can use the gamma to image it. And in this case, we image it. The energies are for SPECT cameras. So we use SPECT to image them. And this therapy is manufactured by Novartis. So they're the ones that are making it available in Canada at the moment. So what is involved in this therapy? So what has been approved in Canada is So hopefully some of you are familiar with some units in radioactivity. I didn't go over that, but so what's approved? It's 7.4 gigabecquerels, okay, or 200 millicuries every 6 weeks, and we can give up to 6 doses, or there's on or until there's unacceptable toxicity. We can reduce the dose by about 20%, but once you reduce the dose, you can't go back up. So we try to keep it at 7.4 gigs every 6 weeks. So the patients keep coming back. The patients keep coming back after every administration. Um, and this is this is what we're giving them. The main clearance is through the kidneys. About 70% of it is excreted in the first 24 hours, which is great because that means that after we give it, our patients don't stay radioactive for too long, and that's going to come up later. So the main organs that are at risk, so other than binding to prostate cancer cells, there's some PSMA in kidneys, in the bone marrow, and the salivary glands. So those are the main organs at risk in this case. And so the reason why it was approved in Canada and in other countries is because that one of the main trials that was done for it is called the Vision trial. And it did find very significant overall, longer overall survival and extension of radiological progression-free survival when lutetium PSMA was given in addition to the standard of care. So, and the change in overall survival was about 4 months. So like 11 months compared to 15 months for just lutetium. And I have to say, so these are patients that have already been. There's a lot of things that these prostate cancer patients have already tried. So this is one of the last things that they would try. So, and even in that case, there was still significant benefit for it. So it was approved. The most common side effects, because of the other organs that it binds to, the most common side effects that we get are dry mouth and fatigue for it. So quite a few of our patients, have this, but overall the treatment is really well tolerated. Very few adverse events that are higher than grade 3. So it's actually really, really well tolerated. So it's being used a lot. Again, I will say it again, it's the use for this therapy has almost exploded. In the US, they have built treatment units just for this therapy because there's been so many patients that have been getting it. Okay, so the therapy is administered, it's well tolerated, and the other good thing about it is that you can image it, and I will say that you can image it for free. So after you give lutetium, the gammas are there. You can bring back the patient and just image the patient. So you don't need to do anything else for it. And it has the gammas that it has. The main gammas that it has are at 113 keV and at 208 keVs. So it's not a positron emitter, so you can't do PET with this. So you need that gamma camera. And once you have the gamma camera, you can do either planar images or SPECT images with it. And again, because it's already the radiopharmaceutical has already been given to the patient, you can use it to monitor response to the treatment after you image them, and we can also use it for dosimetry as needed. So here are some images of the same patient taken at different time points. So 90 minutes post injection, 6 hours, 24 hours, 48 hours, and 7 days. So in lesions, the peak uptake for lesions is around 24 to 48 hours post-administration. In the earlier time points, you see more activity from the rest of the body as the radiopharmaceutical, is being distributed across over the body. But so the peak in lesions is about 24 to 48 hours. So if you can bring back the patient, you can use it to monitor how the uptake in deletions is. What the uptake is are the lesions going away? Have there been more lesions? So it's really useful. So it's a great radiopharmaceutical. So we want to start using it. how did we go about start using it in the clinic? So in BC, it had been so BC Cancer is the health agency that manages the cancer treatment across BC. And their decision, so it was approved by Health Canada in 2022. So BC Cancer decided to publicly fund it in late 2024. But BC Cancer doesn't have the distribution of centers to be able to provide this therapy across BC themselves. So, and they had only been doing it as part of clinical trials as at their Vancouver center. So they have four big centers in total in BC, but they had only been doing it in one. So now after they made the decision to approve it for clinical care in 2024, so now the question was, how do we do it? So if we want to start giving it to patients across BC, how do we do it? So other than BC Cancer, we have 5 health authorities in BC. So it's there on the map. You can see how they're distributed. So now the decision was made to start a Pluvicto provincial program and partner with BC Cancer and our 5 health authorities to figure out how we're going to do this, how we're going to start to give this therapy across the province. So this is where we started to break down. So what do we need to do this? So it's only been so far, it had only been done as clinical trials in Vancouver. Now, how can we bring it to the rest of the province? And so this was the work that we did last year. So just to give you an overview of the things that need to happen to be able to do this in the clinic. So we need to develop the clinical workflows. Okay, so what patients are eligible, how is their blood work, how are they doing clinically? We need that. Then we need to actually develop the procedures to give out the therapy. How are we going to give it out? And if we're going to be handling all this radioactivity, I mean, 7.4 gigs of lutetium it's quite a bit of activity. And we're going to be handling that multiple times for same patients, multiple patients. And lutetium, it's a new radiopharmaceutical for everybody else in BC. Nobody had worked with lutetium before, so only BC Cancer. So lutetium now is a new radiopharmaceutical for every other NUC-Med department across the province. So now we need to get everybody used to using lutetium, and we need to make sure that the equipment that they're using is appropriate to detect this new radiopharmaceutical. Then we have to get approval from CNSC. So CNSC is our federal regulator in nuclear medicine. They are the ones that give us the okay to actually perform the therapies, to actually receive the material. We're allowed to receive this material, and now we're allowed to give it to patients as a therapy. So we have to ask CNSC for approval to do this. And then if we want to image it, yes, if we want to image it, we need to make sure that all the SPECT cameras that we have are appropriately calibrated to image lutetium. And to give it to patients, we need to also perform calibrations on the dose calibrators. Those calibrators are the equipment that actually measure how much radioactivity you have before you give it to patients. So there's a lot of equipment we need to calibrate to make sure that we're giving the correct doses to patient, that we're imaging it properly. And then we have to decide what protocol are we going to use to image it. And all of that needs to be done before we actually give the therapy to patients. So BC Cancer was the only one who was doing this in Vancouver. Nobody across the province had ever done this. So the development of clinical protocols, that is on BC Cancer. That's led by BC Cancer because it's they're cancer patients. But everything else associated with actually giving the therapies, then that is now going to be done by nuclear medicine departments across the province. So each health authority and each nuclear medicine department has to figure out how to do all this so that they can actually give out the therapy. So it's not easy. It's a lot of things that need to be done before you can actually just give it. And so what was the status? So so obviously you need radiation safety support, you need physics support to do this, you need SPECT cameras that are in good shape to do this. You need, so what's the status? So across the province, this is generally how many nuclear medicine departments we have across the province, the SPECT cameras that they have in total. Do they have radiation safety officers? And do they have medical physicists to support clinical procedures? So in total in BC, so in all of the health authorities, in total, we have about 24 NUCMED departments across the province, and we have about 52 SPECT cameras across the province. And we have physicists, nuclear medicine physicists at 2 of the health authorities, and there's only in total, so there's me at Interior Health, and there's 3 folks at BC Cancer. So there's only 4 of us across the province. And so we support our health authorities, but also most of the time we also support other health authorities too, because they don't have someone else. So out of all of this, so out of all the 24 departments and 50 SPECT cameras, which ones are we going to use for this? So this is where we started to work together to figure all this out and to figure it all out, everybody at the same time, to save, just to make everything more efficient. So we took a province-wide approach to this. So we knew we wanted to have it across the province. So we started to talk to each other, and we started several working groups. So we started a provincial working group with BC Cancer and all the health authorities. Then we started working groups within our own health authorities. And then we also separately started a SPECT CT working group to figure out how we were going to do the SPECT CT across, for everybody. So we started to talk about it, and we started to have all the discussions that we needed to have about all this. And what we wanted to do is, so how are we going to start to organize all this? So make sure we're talking to the important people for all the health authorities, identify the challenges at each health authority. What do they need? What do they lack? And then key thing is share resources and documents, because there's no point in one person working on something and someone else reinventing the wheel. So before everybody just starts and works on something, let's share resources, let's share documents between all of us. And the good thing about this is that if we do it all at the same time and we do it all together, we can standardize the way we're going to give out the therapy across the province and the imaging practices that we're going to have across the province, which is a huge plus if everybody's doing the same thing or as close to the same thing as possible. So the first thing that we did was, of course, narrow down. So where are we going to do it? So each health authority had to go and figure out, so what are the best departments out of all the departments that we have and all the SPECT cameras that we have, which ones are the best ones to start to do this? Which ones would be the more prepared to do it? So we narrowed down which departments and which SPECT cameras we would use for these therapies across BC. So each health authority decided which departments they would use and which cameras they would use. And so in the end, we decided for about 10 NUCMED departments giving out the therapy across BC and about 24 SPECT cameras doing the imaging. And for us in Interior Health, so the health authorities close to Vancouver, their geographic spread is a lot smaller, as you can see from the diagram, than in the interior BC or northern BC. So we decided to try to spread it out a bit. So we are going to do therapies at 2 sites, and there will be some sites that are just for imaging. So if patients want to go back to get imaging closer to home, they can. So we did narrow it down. So 10 departments across the province, about 20 something SPECT cameras, but this is still, we need to get each of these departments ready to give this therapy, and we need to calibrate all this equipment to be able to do it. So after this, we started to chop away little by little to everything we needed to get done to do this. So first, we did because we're involving BC Cancer, and BC Cancer is a different health authority than all these other regional health authorities. So we needed to start a provincial coordination team. So a team that would get all the referrals for Pluvicto and then fan it out to all the health authorities and to all the centers, whatever BC Cancer centers were regionally, to follow up the patients and to order labs and blood work and things like that, and then pair those BC Cancer centers with our health authorities so that we can then schedule the treatment dates, schedule the imaging dates. So this needed to be coordinated provincially. So a provincial team was created. So, and there's a lot of talking, a lot of back and forth between them. But so that's what needed to happen. So we did create a provincial team to manage all this. And on the NUCMED side, like I said, we just started to chip away at all the different things that we needed to get done. So some of the first things is we actually need to develop the therapy procedure and assess what radiation equipment each of those departments has, so that we can get approval from CNSC to perform the therapies. So just to give an idea of all those little things that went into that one. So we know, because this has been done, clinical trials for a long time already, we know this can be done as outpatients. So the patients don't have to stay in the hospital for this. So we know we can do it as an outpatient. And the kind of documents that we need to apply for CNC approval, how we're going to do the therapy administration, where are we going to do it in the departments, what safety practices our staff going to follow, how we're going to manage the storage and disposal of the contaminated waste that we're going to have, the instructions to patient, what do you tell patients? So this is an outpatient. So patients are going to leave the department after the therapy. They're still going to be radioactive when they leave. What are you going to tell them? How long do they need to distance from others? Do they have to follow precautions for the bathroom? And for their caregivers too, what instruction you're going to give to caregivers. And if there's a medical emergency for these patients, so they come back and they need medical care while they're still radioactive, what are you going to say? So all those things we needed to develop for all the departments, for all 10 departments that are doing. But the good thing is that a lot of this was already known, like I said, so we didn't have to reinvent the wheel too much, because it had already been done for research. But now, how do we actually do this in the clinic with the resources that we have at the clinic? And and also, with the limited resources that we have at each clinic. So one of the first things, of course, is always the safety to staff, because they're going to be handling this. They're the ones that are going to be handling this activity and injecting it to patients. And for like I said before, so the main energies for it are 113 kV and 208 kV, and it also has a beta. So the safety practices have to account for both the betas and the gammas. And the good thing, I'll show you. So the good thing is that this radiopharmaceutical is actually, when it comes to exposure, it's actually a lot lower, because even though it has gammas at 113 and 208, the abundance for those emissions is on the low side. So actually the exposure from it, once you're at a distance from it, is actually quite low. So a lot of our nuclear medicine techs are familiar with I-131, because that's the therapies that we have been doing for a long time. This one, the exposure that you get from lutetium is about 1/10 of what you would get from I-131. So it's really, so even though you're handling a lot of activity, the exposure from it when you're away from it is not that high. But if you get contaminated with it, if one of our techs has an accident and they get contaminated with this, once it's on your skin, the exposure is not low. It's high, because it's a beta emitter. So once it's on your skin, the contamination and the dose to the skin can be high. So of course, the first questions the technologists are like, what do I need to do? What am I going to wear? What shielding do I need to use for this? Do I need to wear a lead apron? Do you need to wear a lead apron? Because for I-131, we don't. because the energy for it is 360 keV. Lead aprons are not going to stop I-131. So we tell them not to wear lead aprons for I-131. But then for something like lutetium, should they be doing it? So these are the kind of things that we had to, make decisions about. What are we going to tell? What are we going to tell the techs to do? And in the end, it's the usual things that you would expect. They have to wear gloves, gowns, they have to use tongs to avoid direct handling, they have to use shields for the syringes and the vials. And in this case, they can wear lead aprons to reduce their exposure. So once we figure all this out, no need for different health authorities to reinvent the wheel. We just share what recommendations we come up with all health authorities. And a lot of this, there were subgroups of NUCMED RSOs and us as medical physicists figuring all this out. What exactly are we going to tell the technologists to do? And one of the main things that we do also have to figure out are the precautions for the patients. So what are we going to tell patients? And you would think, so these therapies have been used in clinical trials, so there must be standard precautions that you give to patients already. Yes and no. So CNSC doesn't have standard precautions that for this radiopharmaceutical, you have to tell patients this, for this one, you have to tell them that, because they allow for variations. So organizations can be as conservative as they want, as long as what you're exposing others to is below limits. It's below the CNSC limits. So so some organizations might say you can't, you have to sleep, the patient has to sleep alone for 10 days. Someone might say for 7 days. So because 7 is enough, but some folks maybe want to be a little bit more conservative, so they say 10. So, but then so now we have to figure out what exactly are we going to be telling our patients? And what are all the NUCMED departments across the province going to be telling patients? So of course, we started to look at this ourselves. So what is the data out there for how the dose rate decreases from patients over time? And like I said, so the good thing is, yes, the dose rate from lutetium is relatively low for it being a therapy isotope. So once you're away from the patients, the dose rate is quite low, but it's also excreted very fast, which is another good thing about it. So it's about 70% excretion in the first 24 hours. And it's and the data that it's out there right now, it says it's maybe most likely it's a bioexponential decay. But there's data out there now that shows all that. So we took all that data, and then with these estimates of what the exposure is for patients, now we go and estimate what the exposure to others are. If the patient has a spouse, if the patient has a child, if the patient needs to go to work the next day, what are we going to tell them? And so with this data, so we ran through various scenarios and various exposure cases, and we develop our own precautions of what we're going to tell our patients. And again, if somebody is figuring all this out, there's no point in everybody reinventing the wheel. We just shared what we have with all health authorities across the province. So again, so this was us medical physicists figuring all this out and what the recommendations should be. So, and sharing it with everybody else. The other thing, so before we can actually have permission from CNSC to do this, the other thing we had to do was assess the radiation equipment that each department has, because now you're going to be handling this new isotope that's lutetium. What if you spill it? What if a patient vomits? Or like what happens if you have a spill of this isotope? How do you have the equipment to detect it? If it's a person, how are you going to be handling a person who's contaminated? So we had to assess the equipment that was available across the province, and the key things for that equipment is the sensitivity to lutetium. So how much, if you detect counts with this equipment, what does that mean? How much activity is that in becquerels? And then the other parameter that CNSC cares about is the minimum detectable activity. So is this equipment good enough to detect the lowest amount of the isotope that CNSC has as its limit? So the good thing is that a lot of nuke med departments have very similar equipment because we're all doing the same thing. So a lot of the equipment is the same. So if we figure it out for this one model, and then if other departments have it, it should apply to them as well with some wiggle room in there. So as physicists, we went about to figuring all this out, what the estimates for the sensitivities and the minimal detectable activities would be for lutetium. So if nobody had used it before, we had to make estimates from what is done for other radionuclides, so what the characteristics for each detector is. And again, we shared the results with everybody else so that everybody was doing something similar. So now that we have those, and this is, so here's an example. So these are what our guidelines to the patients look like. So for 5 days, they have to maintain distance, and they have to sleep alone for 5 days. For 10 days, they do this. For 7 days, for 3 days, they do this. So those are the kind of things that we develop for the patients. And so now that we have all this, we share all these procedures and documents with all the health authorities, and now everybody can go and apply for CNSC approval to actually perform the therapies. And the request to CNSC has to be done by each health authority. So each health authority submits the request with their documents. It's done by their radiation safety officers. And then all the other safety officers and us nuclear medicine physicists, we provide support to them, but this has to be done by each health authority separately. So everybody went ahead and did that once we had all these documents ready for each of them. And I have to say, CNSC didn't deny the request, so they approved all the departments were approved to do it. They deemed that they were ready enough to actually be able to do it, so they approved the request. So now the few last things that we needed to do was do calibrations for a few other equipment, like I mentioned. So those calibrators that we're going to use to actually measure the activity to patient, the SPECT cameras, and to develop the actual imaging protocols, what we're actually going to use to image the patients. So those calibrators are really, really important because they're the ones that measure the activity that you're actually going to give to your patients. And nobody, none of those departments had ever used lutetium before. So we had to make sure that their dose calibrators were appropriately calibrated for lutetium. Because we give 7.4 gigabecs plus or minus 10%. So that's the clinical allowance. You can be off by 10% of that activity, and you're still okay to give to patients. So if the activity is outside of that range, then you can't give it to patients, and you have to figure out why. So we have to calibrate that equipment to make sure that it's okay, that what we're reading is accurate. And the Novartis, who's the manufacturer for Pluvicto, they can give us calibration activities that they send to us. However, because BC Cancer had been doing this for clinical trials for a long time, BC Cancer noticed that the calibration activities that were coming from Novartis were actually not well calibrated. Like they had errors in their activities of up to 12% sometimes, which clinically is not, we can't use that for patients. If the way Novartis is calibrating their activities are not correct, then we can't have those kinds of errors with what we give to patients. So in short, we didn't quite trust what Novartis was sending us. So what we did then is what we decided with the physicists at BC Cancer was that we were going to develop our own process to calibrate those calibrators in BC. So instead of using the doses and the values that were coming from Novartis, instead BC Cancer was going to receive those calibration doses. They were going to confirm what that value is, and then send it back to the nuke med department. So we changed it. So we developed this specific process for us. So it involved BC Cancer receiving the doses and sending them to the nuke med departments. But this had to be very it required very careful coordination because the dose is decaying, right? It's 6 days, it's 6.5 days. So we can't give it to BC Cancer, and BC Cancer takes a week to do this, and then they send it back to us because in a week it's already been decayed by a lot. So we had to time it so BC Cancer gets it, they do it really quick, then they send it to other departments across the province. So this took a lot of coordination to make sure that the timing worked out okay. But so we did it because the readings from Novartis were not accurate. So but we did it and we got all those 10 departments calibrated. Their dose calibrators got calibrated this way. So that was great. So the other thing we needed to do was check the 20 plus SPECT cameras to check that they were appropriate for imaging lutetium. So we had to make sure that the performance for those cameras was appropriate. And one of the key things that we do for SPECT cameras is we check the uniformity. So for SPECT cameras, we have sodium iodide detectors, right? They're scintillators and they have PMTs and stuff like that. So we had to check that when we're using the lutetium energies, that the response of the detector and the whole system is appropriate. And usually what we do in NUCMED is that because technetium-99m is the main diagnostic isotope that we use, that's what we calibrate the cameras with. Because that's, 90% of the images that we take for SPECT, well, maybe 80, is technetium-99m. So we calibrate the equipment at 140 kV, but lutetium is not at 140. So we had to check that for all the cameras, those 20 plus cameras, are they performing okay so that if we image at the lutetium energies, it's still a uniform response, the correct response for all of those cameras across the province. And to give you just a quick example, this is what the spectrum of lutetium-177 looks like on those sodium iodide cameras. So this is the 208 peak, and that's the 113 peak. So, and the cameras are calibrated for 140. So the cameras are calibrated in between those two. But are those calibrations good? Like, if the camera is performing well, it should have a more or less uniform response across a fairly wide range of energies. So if the camera is okay, even if we have calibrated it for 140 and we decide to use the 208 peak, it should still be okay. It should still perform okay. And that is one example here. This is a uniformity check. And that is appropriate. So that is okay. So even though it's been calibrated and corrected for the technetium energies, it's still a uniform response and an appropriate response at 208 kV. So, but we had to do this for all the cameras, all 20 plus SPECT cameras across the province. And we did find some where it was not okay. So this is one camera where that uniformity check failed at 208 kV. So in this case, something was going on with this camera that it was not responding appropriately. So what we figured out in the end is that it was failing because the technetium corrections and calibrations were failing already. So the camera had been drifting from calibrations, and actually technetium had started to drift already, but they hadn't noticed it because it wasn't as bad. But once you look at 208 kV, then you can tell that, oh, the camera is starting to go off from the calibrations. So once we recalibrated this camera with technetium, the lutetium uniformity was acceptable for this too. So what this taught us was that as long as the cameras are properly calibrated with technetium, we can use that for lutetium. So, which was, a big time saver, because that means we don't have to calibrate each camera specifically for lutetium. As long as technetium calibrations are okay, you can use that for lutetium. And again, we shared those kinds of results with all health authorities, so nobody had to reinvent the wheel. But that still meant that all 20 cameras had to be checked for this to make sure that their performance was okay. And okay, and the other thing that we did for the camera, so check that the response to lutetium was okay. The other thing that we did is develop calibration factors for lutetium. So calibration is the factor that allows you to convert from counts to activity becquerels, so that we can use that for quantitative analysis like dosimetry if we need to. So for that, you need to image a known activity. And there's a specific phantom that has been used for that, for lutetium specifically, where you have, this, if you can see, there's a bottle here that you put inside this phantom, and then you image it in the SPECT cameras, and then you get an image like that. So you know how much activity has gone into this bottle, and once you run it through all the reconstructions and everything, and you know how many counts, then you know how much activity there is here. So you can do those, you can use that for dosimetry, how much activity is in that lesion, hasn't gone down. So we needed to do this for all cameras. So for all 20 cameras, again, we needed to do this. But before we could image this phantom, we had to decide what imaging parameters are we going to use clinically, because to image this calibration phantom, you have to image it the same way that you're gonna image patients. And so that was part of the SPECT working group that we have to determine, so what clinical parameters are we going to use. And so one of the things we decided is, again, so here's the spectrum for lutetium. One of the things we decided, and of course, there's been therapy papers published and everything, and a lot of the physicists at BC Cancer have been doing this, is that we were only going to use the 208 keV peak to image it. We're not going to use the 113, and that's because this is a cleaner peak. So around the 113, there's a lot of scatter. There's a lot of scatter that affects the image quality. So the 208 peak is a cleaner peak. So and we can center the imaging window at 208, and we can have scatter windows around it, so that we can make an image of what the scatter looks like for a specific patient, and use that for scatter correction. So we had to decide so SPECT cameras, you can program them to image specifically from this energy to this energy, and I want the scatter window to be from here to here. So we had to decide that. And the good thing is that once we decided, everybody in the province can start to do the same thing. So I mean, I won't go through the details of how we did this, but this is basically what we decided to do. The SPECT cameras rotate about the patient. So how many times are we gonna stop and collect data as we're rotating around the patient? How long are we going to image for? What exact energy windows are we going to be using? All those things we had to decide. And then so that was part of the SPECT working group. So once we did this, we could go back and image that phantom with those specific parameters. But again, that calibration phantom, there was only one of those in the province, and it belongs to BC Cancer. So again, we had to coordinate to send that phantom to all the different departments in BC, so that they could also image it. So there was a lot of coordination through all this. But again, the good thing is that once we had decided that, how we're going to image patients, how we're going to image the calibration phantom, then everybody in the province is now doing the same thing, which is amazing. So those were the last steps. So calibrating the SPECT cameras was the last steps before we could start to image patients. So it took a long time, took lots of work, but now all health authorities that had decided to do this, now they're using the same SPECT calibrations and clinical acquisition parameters. So from the beginning, we were able to standardize the image acquisitions across BC. And that is going to be so great, because it allows for better clinical comparisons. The physicians can look at images from different sites, and they know that the images were acquired the same way. And it allows us to do better research, because everybody's doing the same thing. And because, well, not unfortunately, but it is what it is. There was so all these calibrations for the equipment, they're not very straightforward and everybody's busy. So a lot of us, or the 4 nuc med physicists in the province, we had to travel around. So, we had to travel around to help the different departments settle this up. So I didn't get to go to Prince George, but some of the physicists in BC Cancer went all the way up to Prince George to make sure that their cameras were calibrated. So, but yeah. So even though we did have some standardization, we still had to be flexible because you know, uh, not all cameras are the same. So some health authorities have spec cameras that are over 20 years old, and they just cannot do some of the things that the other cameras can do. So we had to have some flexibility for what some of the older cameras can do. We also had to have some flexibility of when that imaging is going to happen after the therapy. So ideally, it would be at 24 to 48 hours after administration, but some patients can't wait. They need to go back home, so we had to have flexibility in that. So the recommendation we gave to everybody was that they should image 24 hours post administration, but it can be done earlier if they want to. If the patient needs to leave the same day, you can image them at 4 hours after administration instead of 24. But what we are telling somebody is just to be consistent. Like if you're imaging patient at 4 hours, image them at 4 hours after every cycle. If you're going to image them at 24 hours, image them at 24 hours after every cycle. So for each patient, you can compare how things have progressed, if the disease have progressed. And also we had to also be flexible in what cycle is the image going to happen. Is it going to happen after all 6 cycles, or is it only going to happen for some cycles? Because not all departments can squeeze in these many therapy patients. They're also imaging bone scans, heart scan, so some sites don't have the capability to image after every cycle. So we did have to be flexible in that as well. So each department can decide what cycles they're going to be imaging. But at least when they image, everybody's using the same parameters. So that's great. So just to wrap it up a bit, so everybody was able to start within a year. So we were able to start the whole province, all these departments, and calibrate all this equipment within a year. The last department came online in February of 2026, and that was Prince George because they're a bit far up, and it took a while for us to get to them. So, but now we're able to offer this to patients across the province, and they're able to get this treatment closer to home instead of everybody having to go down to Vancouver to do it, which is amazing. And in the, we've been online less than a year. We've done over 150 patients, more than 400 cycles we've been administering. We've taken more than 300 images right now. And we've started slow, because everybody had to get used to the process, to the imaging. So we've started slow, and we're only, like I said at the beginning, these therapies are only going to be increasing. So this was great lessons learned for everybody, what we needed to do. Yeah, and just to show you, so for example, some of the images, just to show you some of the images. So this was actually the first patient. Oh, sorry. So this was the first patient that we imaged at Interior Health. So after cycle 1 in October, and now after cycle 4 in March or so. So everything that you see here, that's the spine, right? So that's the spine. Everything that you see here is lesions. So this patient had a lot of lesions in the spine. And what we can say for sure is that the amount of uptake in the lesions has gone down, but the number of lesions has increased, unfortunately. So he had started, his PSA had started to go down in between cycles, and then in cycle 4 it started to go up again. So maybe the therapy helped to control the disease for a little bit, and then there's been further spread in the last data that we had for him. But now we have this kind of data for all patients that are receiving this treatment. And we did have one recently that seems to be that there are some patients that are super responders, that really seem to respond really well to this treatment. So this was the image after the first cycle. lots of lesions. And then just on the second cycle, very large decrease, a big decrease in the amount of lesions and the amount of uptake in those lesions. So maybe this one patient, he's only had 2 cycles though at the moment. So, but like maybe would be one of those patients that maybe a super responder, and it's gonna respond really well to the treatment. So, okay. So yeah, so what worked really well for us is that, like everybody across the province came together. We shared resources, we shared documents, and that sped up the whole process. And standardizing the imaging and the calibration from the beginning has been really helpful. But at the same time, we still have to have some flexibility in what we are doing. The big challenge that we have is people. Like staff shortages for nuclear medicine technologists. We asked them, oh, can you run this calibration scan? Oh, we can't, we don't have time. So there's staff shortages all across healthcare at the moment. So definitely that slows down implementing something like this, because there's just not enough people to do it. And of course, us as well, there's only 4 of us, 4 nuclear med physicists in BC. So coordinating all this took, like this was our life for a while, coordinating all of this for all these departments and all this equipment. And also some of the other challenges we've had is because it's so big, it involves so many health authorities, messages get lost. Blood work gets missed. Some patients are not eligible anymore, but they told us to schedule them. Just because it just involves a lot of people. It involves a lot of people, and it involves a lot of health authorities. So the communication and the coordination between all the different players and all the different health authorities, we need more people. We need more people. We do have that provincial coordination team, but we're going to try to get staff specifically assigned just to this therapy to help us coordinate everything, because there's so many moving parts on this as well. So yeah, so that's actually, yeah, so I will leave it at that. Sorry, ran a little bit late there. But yeah, so definitely lots of things. So many people were involved in this. I'm not gonna list them all because there's dozens and dozens of them. The ones that I will, just because we're in physics folks here, I'll just mention the other physicists at the BC Cancer. The 4 of us were the ones that took a lot of this on, and we were able to work together to do it. So it was great. Okay, I will leave it at that. Yeah, thanks everybody.
Great. Well, thank you so much. Congratulations, by the way. This looks like a major undertaking. I can only imagine just the coordinating between different institutions, health centers. I wouldn't want to be able to do this myself. So well done. Very impressive. We have time for questions. I see there already is one in the chat that I'll read out loud. Oh, there's 2 in the chat. So the first one's from Malcolm. I'm assuming McEwen. He says, in all the calibration steps, do you have national traceability, or is everything just related to BC kids, or how can NRC assist with developing national consistency of calibrators and scanners?
Oh, that's great. So basically we would need a long-lived source, because lutetium decays in 6 days. You can't have one lutetium standard. So we would have to develop a standard that mimics the lutetium spectrum, and that's long-lived to be able to have. Yeah, so that's what we would need. So something that mimics all the emissions from lutetium that is long-lived, that we could use at different departments. Are we able to do that? If the NRC could assist with something like that, that would be lovely. So yeah, so maybe something to chat about. Yeah, so good question. Maybe something we can chat about at some point. So yeah.
Okay, great. And there's another question from Victor. He asks, thanks for the great talk, very informative, amazing job. He's not sure if he heard correctly, but Novartis is the main lutetium-177 provider, right?
Correct, that's right,
Right.
yes.
Question 2. It's a 3-part question.
Okay.
If so, do the approved nuclear medicine departments in each health authority perform patient image-based dosimetry, or is it performed by Novartis?
It's performed by us. So yeah, Novartis is not involved in the dosimetry at all. They just give us the doses, and we give it to patients, and then we do dosimetry however we want to do the dosimetry. Yeah.
Okay, great. And rounding up the trilogy, if the nuclear medicine departments perform image-based dosimetry, how is this dosimetry performed? Do you use any commercial software? Do those commercial softwares have limitations that make dosimetry challenging?
Yes. Yes. That is the dosimetry that could be a whole different talk. The dosimetry is something that we're actively working on because there is no standard dosimetry protocols at the moment. There's no standard dosimetry software. There's protocols out there, there's softwares out there, but there's nothing that the industry has said use these parameters, use the software. We don't. So that's something that's very much work in progress, and so everybody's working towards trying to standardize that. There isn't anything standard at the moment. We've come up with a protocol that works for us for now, and we're going to investigate that protocol and see how that goes. But yeah, dosimetry needs to be standardized. Yes.
Sounds like. Great. Raphael, would you like to ask your question?
Yes, thank you. Excellent job. This is a gargantuan effort. First I'll introduce myself. I'm Rafael Gallia from the National Research Council and responsible for radionuclide metrology.
Excellent.
About the national traceability of BC cancer, I think I know something about that. And in particular, I believe that was done for Lutathera. So one of the things that would be critical is to redo that traceability, and certainly we're here to help with that, to have traceability to Canadian national standards.
Ooh.
I also think, and I would be happy to be involved with your working groups to offer any calibration assistance or questions that maybe I can assist in terms of the measurement side of things. So please get in touch, and I'd be happy to join those working groups.
Excellent.
What I wanted to sort of indicate also is that when you calibrate, you're calibrating for a certain geometry. And so are you looking at different calibrations for example, a syringe or even that larger bottle that you're using for your Phantom? Are you deriving separate calibrations for those?
No, not for the big bottle. The only calibrations we have are for the vial that comes from Novartis, because that's a standard vial that comes from Novartis. And then we also standardized the syringe that everybody's using. So we calibrated the vial and we calibrated the syringe. And the bottle, we don't have equipment that fits that. So basically we just calibrate the syringe and the activity that goes into the bottle from the syringe, basically. So those are the two geometries we calibrated. Yeah.
Right. Well, as I said, I'm happy to help and also offer the traceability for those other things that we take for granted, which is the fluorine 18, other PET imagers, or even Tech 99 metastable. So again,
I will get in touch with you. Thank you so much.
Looking forward to it.
All right, thanks. It's good to know the NRC is on our side. Malcolm makes a comment here. The BIPM is collaborating with the IAEA on guidance on RPT and quantitative imaging. So
excellent.
Glad smart people are thinking about this.
It's a lot of work. It's a lot of things. Yeah.
Are there any questions from the room? I don't want to leave you guys out of it. Not so much. Any other questions online? Raphael, one last one.
Yeah, thank you again. I just wanted to make another point. I mean, if your calibration is better and traceable, which I think you guys are doing already a very good job, can you not think about delivering a lower dose for the same biological impact? Or would that require a full-on, preclinical trial again?
Yes.
Okay.
Yeah. That is what the protocol is, because the protocol is based on the clinical trials, and we cannot deviate from that for clinical use. So.
And if I may ask one quickly, so I've seen a lot of these lutetium patients that perhaps do not respond. Then they are switched to actinium-225.
Mhm.
Do you foresee that starting up in BC
Yep.
intensive?
I am
Okay.
sure it will. I mean, we have Triumph just in our neighborhood, right? And Triumph is one of the sites that's working to develop actinium-225 for broad clinical use. So yeah, I am sure that's coming our way. Actinium is coming our way. There's a lot of other radionuclides are coming our way. So I'm glad we started this, because now, like, we have the groups and the knowledge to expand it as when the other ones come. So yeah.
It's great news. RPT is maybe going from palliative care to
Absolutely.
potentially curative care. So it's a
Absolutely.
really a golden time.
I
For
know,
it.
it's
So
wonderful. Yeah.
congratulations.
Yeah. Thanks.
Okay, super. Well, thanks so much. I think we'll close the session. We'd like to thank Dr. Gonzalez again. Fascinating talk. Thank you all for being here. Have a good rest of your Friday and a good weekend.
Thanks, everybody.
Bye-bye.
Thanks. Bye.